Rahim. I start with a few verses of the Holy Quran. Bismillahir Rahmanir Rahim. Kul huwallahu ahad, Allahu samad, lam yalid wa lam yulad wa lam yakun lahu kufuwan ahad. Sadaqallahu azim. Uh, my name is Dr. Asad Chaudhary, and I represent Project ECHO in Pakistan. And with PARSA Trust and collaboration of Project ECHO, we are the first super hub in this area, just commissioned recently in February this year. And today is a big day for us because on the day of World Hepatitis Day, we decided in collaboration with Pakistan Society of Hepatology, Punjab Hepatitis Control Program, Health Foundation, to have a sitting of experts and the people who are working in the field of elimination of hepatitis in Pakistan. We are greatly honored to have representation from World Hepatitis Alliance, and we really look forward to learn more about the international experience in the field of hepatitis elimination, because that's the biggest challenge we face. A few hours back, we were in a meeting and where it was, highlighted by Professor Saeed Hamid that COVID so far has caused between February 2020 and July 2021 around 23,000 deaths in Pakistan. And in this time period, hepatitis has caused more than 35,000 deaths in Pakistan. So somewhere we are lacking. We have a huge challenge at hand. So I have a list of great colleagues from Pakistan and from Egypt. This session is going to be chaired by Professor Anwar Khan. He does not need any introduction. He's teacher to almost all of us, our mentor, and even probably he will not know how much we try to emulate his example and follow him and try to make a difference in our field. We have honorable co-chairs, Professor Sayyid Hasnan Ali Shah. I think he will be joining soon. Professor Javed Iqbal Farooqi, who is an ex-professor of medicine from Lady Reading Hospital, Peshawar, and Professor Altaf Alam, who is also the course director of PARSA ECHO Pakistan and a driving force behind our hepatitis ECHO and other ECHOs programs that we are launching. In our faculty today, we will be listening to Dr. Khalid Mahmood about eliminating hepatitis, what's happening in Punjab. Khalid Saab is Program Manager, Punjab Hepatitis and Infection Control Program. And I'm really thankful to you, sir, because you're traveling and he's been joining from Multan. So he took his time and he committed straight away that he will be joining us. Then we have Dr. Huma Qureshi. She will be talking about National Hepatitis Control Program, where we are standing now. She is Tamga Imtiaz holder and Executive Director of Pakistan Medical Research Council. Then we will be very keenly listening to Dr. Jamal Shiha from Egypt. He's Executive Board Member of World Hepatitis Alliance for Anglo. And finally, Kashif Malik, who is heading the gastroenterology department of Sheikh Zayed Hospital. He's also president of Pakistan Society of Hepatology. And then we would like to listen to him about the way forward from here. So without any further delay, we will have 10 to 15 minutes time for each speaker so that we have some time for our chairpersons and co-chair, and then depending upon time we'll be discussing, and maybe the objective is to have some guidelines how we are going to proceed from here. So Dr. Khalid, it's over to you. If you can briefly introduce yourself about your work and then your presentation. Over to you, Dr. Khalid. You have to unmute. Uzair, can you unmute Khalisa? Ji Khalisa, please. Oh, you are muted again. You are sorry, you are muted again. Uzair, can you help here? Yes.
Can you hear me?
Yes, we can hear you.
Assalamualaikum, everybody. Thank you, Dr. Asad, for creating this opportunity, and especially in line with the activities which are being organized nowadays for World Hepatitis Day 2021. And this year, we all know the World Hepatitis Day theme is Hepatitis Can't Wait. And Dr. Asad proved that he could not wait for the 28th of July. He just gathered all the colleagues, on 15th of July. This is the spirit. This is the, actually the effort, magnitude of efforts which we all need to fight against this menace of hepatitis, especially in Punjab. I'm talking of Punjab. Dr. Huma, did a very important, study in 2008 from the platform of PMRC. That study told that in Punjab, we were at 6.7% prevalence of hepatitis C and 2.4% prevalence of hepatitis B. But later on, everybody knows that government of Pakistan made 18th amendment, and the health became the provincial subject, and the government of Punjab then started thinking of having a homegrown survey for hepatitis. And Dr. Anwar, there was a PC1 from PND board and Punjab Bureau of Statistics involving all the hepatologists, PKLI, other learned colleagues, conducted a survey for Punjab, prevalence survey. And that survey concluded with the remarks that hepatitis C has gone to up to 8.9% from 6.7%, the figure of 2008 in 10 years' time. And but at the same time, hepatitis B was reduced to some extent from 2.4% to 2%. And that is only because of the fact that we all know that we have vaccine against hepatitis B. And our EPI program has included pentavalent vaccine at 6 weeks age, and the second shot at 10 weeks age, and then the third shot at 14th week age. And that EPI program is struggling to provide the vaccine against hepatitis B. But still, the birth dose for hepatitis B have been missing since long. And we all the colleagues were strong advocates for birth dose, for inclusion of birth dose in the routine EPI program. We'll talk about birth dose later on, but I was just mentioning that the prevalence of hepatitis increased from 6.7% to 8 to 9% in Punjab, and that is quite an alarming situation. Recently, we had been working together, and so many meetings, were there at Islamabad. Dr. Huma Qureshi called us over there. There was a tag meeting, and it was calculated that Pakistan is 7%. In general, as the prevalence of hepatitis C is concerned, but Punjab is 8.9%. Having said that, we need the struggle, the efforts, making our all the partnerships alive together, and to create a magnitude of efforts at par with the prevalence of hepatitis C in Punjab. And government of Punjab, yes, they have ADP scheme, they have development project, the project which I am looking after as program manager. This PC1, dear colleagues, was created in 2016, and it has a magnitude of almost 5.69 billion for a period of 3 years. Then the same amount, without adding a penny out there, was continued to be the whole a kitty of Punjab government for hepatitis, that they kept the slab of the budget the same 5.69 billion, but the gestation period was extended from June 19 to June 2022, right? And the same amount of the budget is there to fight against the hepatitis in Punjab. And with that, we established 100 hepatitis clinics in DHQ hospitals and THQ hospitals across Punjab. Later on, this number was, went on increasing year by year. Now, Alhamdulillah, as Dr. Asad will second me, we were hunting partners. Dr. Asad and so many others. I can mention over here, Server Foundation, their clinics. I can mention over here Indus Hospital, their clinics. I can mention over here PSH Pakistan, Social Security hospitals. We are joining hands with the partners so that we can reach more and more hepatitis people in Punjab. And I will just mention that our program started through a paperless dashboard, paperless intervention. This PC1, which I had been talking, was Dr. Numan. We started with paperless intervention, and the first ever client of hepatitis in Punjab at a DHQ or a THQ was registered through unique identifier, that is the CNIC number. We started the activities through a cascade of care, registering the patient, then screening for both the entities, B and C, and then the screened reactive cases. The samples were collected right over there at the clinics, and we had an arrangement that our samples could be transported from every corner of the province to Lahore, our central lab, and we could manage the results of those PCR samples, and those PCR results are available online to the clinic, and our medicines were provided at the clinic site for hepatitis C as well as for hepatitis B, and we are continuing that. But so far as Madam Huma will also second me, the Bristol modeling study, which we conducted on the basis of PMRC, survey of 2008, that demanded that at least Punjab has to take care of 700,000 patients per annum. But with the arrangements I was discussing, we are only touching 100 something, 1,000 patients, and there is a huge gap which is still left. And only thing which lacks is the resources. But a ray of hope is there, and definitely Dr. Huma Qureshi will be talking about that PMPC1 for hepatitis C elimination in Pakistan. We are seeing towards that, looking towards that PC1 of national level, which was developed as a Premier of Pakistan, as a PM Pakistan initiative, and all the stakeholders had so many meetings, and there was a bottom-up approach. People from Islamabad came to the provinces and discussed the real-time situation, and district-based data was gathered, and keeping all those facts in mind, our PC1 at national level was developed. And now, Alhamdulillah, the pre-central development working party meeting has happened, has been conducted, and that PC1 of about 75 billion Pak rupees PKR is lying with Pakistan Commission, Planning Commission of Pakistan, and we hope in due course of time, with the commitment of the government, because this is hepatitis is in the heart of our premier, and they are trying to, arrange resources for that PC1, and they are trying to tap the resources from World Bank and elsewhere. If they succeed in a minimum possible time, then we will have that umbrella PC1 to take care of that huge gap which I was discussing, that we with our budget allocations can only go up to 100,000 and say 150,000 per annum, hepatitis cases, but there is a gap of almost 600,000 patients per annum, and that can only be met through the PC1, which I am discussing from national level. If that PC1 is available, we will be in position to take care of that huge population which is in need of screening. And we know that Punjab is the biggest province of Pakistan, having almost a population of 120 million people. And 120 million people mean there are almost you can say 12 million people who need the services of hepatitis in Punjab. For that matter, we have to screen them. We have to arrange this confirmation through PCR, and we have to provide the medicine, and we have to follow these cases with SVR12 second PCR. And we are doing those efforts through our program. And our strategy is active case detection through microelimination. We had a pilot program in one of the Union Council of District Nankana Sahib, that is Panwa Union Council, where we had a house-to-house campaign to do microelimination for hepatitis in that Union Council. That was a population of 30,000, and our target was 12 years to 50 years population, and that came to be almost 22,000 people. And we touched literally everybody out there from you can say 28th October 2019 to 21st November 2019. And during that period, we screened for both the entities, and we collected the sample right within the community, and the samples were then transported to our nearest THQ hospital, Shahkot, and the same set of cascade of care which we are maintaining at our DHQ and THQ hospital that cascade of care was provided to the microelimination cases of that pandemic. But that was a pilot. That was a successful pilot, and the people from Amro region came over in December 2019, and they visited the community, they talked to the people, and they appreciated the efforts for microelimination. But that was a little chunk, that was just a pilot of one Union Council. And we have high prevalent districts in Punjab, which is 13 high prevalent districts. Generally, we say that we are 8.9%, but our high prevalent district have more than that. The prevalence of hepatitis in those districts is even greater than this 8.9%. And we were planning to roll out or scale up our pilot project for microelimination to the high prevalent districts. But we were caught with this global pandemic, that is COVID pandemic, and we could not go from door to door. And we could not have the gatherings of the community due to social distancing and so many other things. And I must admit that during that COVID phase, our influx of patients also got affected. And so many clinics in our teaching hospitals were closed because of overburdening of the COVID cases over there. And we had to devise other strategies to reach out to the communities. We started delivering full course of 3 months to every client who was diagnosed, so that if that patient goes home and cannot come back, the medicine should not be a problem for such cases. And even we started Zoom meetings with our clinic staff and the doctors, and also we started giving SMS messages on the telephone numbers of the patients who are registered with us in that EMR. So many other things, and also we started developing multiple partnerships during that those days, so that we could reach out maximum number of the patients, even in this phase of COVID pandemic. These were the efforts, and we did we are doing macro elimination through our clinics. We did that micro elimination. We could scale it up, and we are just planning to scale up that micro elimination initiative. We had another very important initiative, that was hepatitis free educational campuses, especially the universities of Punjab. And one of the university, that is Islamia University Bahawalpur, has been declared hepatitis free university in Punjab, and we have gone through MOUs with 17 universities of Lahore, and almost 500,000 population of these universities is our target, and we are planning to start that as we have the space after this COVID phase is a little bit normalized, and we can reach out the students. We are doing with the medical colleges. We are also including the madrasas. We have gone into an MOU with prisons department, and there are 52,000 prisoners in the jails of Punjab, in the prisons of Punjab. We have arranged the resources for these 50,000, 2,000 prisoners. We are going to screen each and every prisoner, and then we are going to establish our sentinel site, our clinic, which is a cascade of care-based clinic in all the jails of Punjab. I mean, we just want to reach out everybody through our meager resources, but when the PMPC1 with the resources will be available, we will be inshallah touching each and every individual of Punjab who need our services for hepatitis. And my learned colleagues will secondly, without that there is no hope. We have to do macro elimination. We have to go for micro elimination. We have to take special initiatives. We have to build partnerships, and our four-pronged strategy is nothing but educate, prevent, test, and treat. And we just tell the people, get tested, get vaccinated, and get treated. And I must share with my colleagues that Punjab has got a legislative backup through our provincial assembly in the form of our legal backstopping. We had hepatitis ordinance in 2017, which was promulgated into Hepatitis Act in 2018, and now we have framed Punjab Hepatitis Rules 2019, and that covers our preventive, cascade of care prevention, so far as the birth dose is concerned, so far as IAD syringes are concerned, so far as hospital waste management is concerned, so far as blood safety is concerned, organ transplantation, dialysis, dental treatment, other procedures are concerned, and high risk population is concerned, and barbers and saloons and beauty parlors. We have registered through our central barbers, beauty parlors, and saloons licensing system 68,000 barbers and beauty parlors on our dashboard. That is another dashboard which is being run through this hepatitis program.
Thank you, sir.
I have so many other things to share with the colleagues, but taking this time constraint into mind, I will hand over the forum to Dr. Asad again. Thank
excellent,
you,
excellent update on Punjab, and we are sure we have some more questions for you. Quickly, I'll move over to Dr. Huma Qureshi to give us an oversight of what's happening on the national front. Yes, Dr. Huma, over to you. I will share your presentation from here. So,
thank you, Asad. So I'll start the moment I see my slides. Yeah, I can see them. Thank you. So as you all know that the World Hepatitis theme this time is Hepatitis Can't Wait. And I'll be talking to you about the hepatitis C elimination plans for Pakistan. As you all know that in 2008, the national survey had shown that we had a HCV prevalence of 5%. And then in 2018, as Dr. Khalid told you, the Punjab did their prevalence and it was 8.9%. And then I undertook the survey in 2019, and that was 6.1%. This covers the Punjab and Sindh cover almost about 80% of the population. And now the overall prevalence has gone up from 5% to 7.5%. The PCR, which was not checked in the 2008 survey, were checked both in Punjab and in Sindh now. And the PCR positivity was 57%. And almost 19% of the population has a history of being treated in the past. The viremic prevalence of the population who has the virus in it, the viremic prevalence is 4%. So that means that almost about 7.3 million cases in Pakistan have the active virus and they need the treatment. And this has put Pakistan as the second hepatitis C prevalent disease country in the world. So that's the statistics we have. And this is really very, very threatening. Next slide. Next slide, Asad. So the risk factors were shown. Asad, can you click because the figures are not coming. So if you just click 2, 3, 4 times, the figures will come. So for the risk factors were compared in 2008 and then in 2018 and 19. And somehow it's not showing in the figures. If somebody could click the down button, you could see, but otherwise I'll just tell you that the blood transfusion was the highest risk factor in the population. And since 2008, there's a 2% drop in the prevalence of the blood transfusion associated hepatitis. But the use of injections, the therapeutic injections that we take for our in the population, for the history of hospitalization, for the history of dental treatments and the history of surgery, all these have really gone up since 2008. And this very, very clearly indicates that our health practices and the health units or the health service sites are not practicing good medicine, and all the infection is actually mostly coming from the healthcare settings. Next slide. Next. Yeah, so you see the figures. So everything has gone up, and this is where actually we all have to really work very hard, because these are the risk factors. Now, if we go on to the drugs that are the medicines which are available for the treatment of hepatitis C, we are very fortunate that Pakistan is producing a very, very good quality and very cost-effective generic drugs for the treatment of hepatitis C. And the cure rate is anything over 96%. Generally, it's about 98%. These are all pan-genotypic drugs, and and you all know that it's the first line of treatment, as the Pakistan guidelines show, is the soft DAC. And if those who cannot, who are not cleared by this, the second line of treatment, as recommended by the national guidelines, is the use of alpha-testware. Next slide. So these are the national guidelines, and we have followed the WHO guidelines, which have been simplified so that these testing and treatments could go down to the grassroots level. And the intention is that everybody should be treated. These are very simple, that you check the individuals for a rapid test using an anti-HCV rapid test. Those who are found positive, you take them through the HCV RNA testing. And if the RNA testing is also, the virus is detected, then you undertake take the blood for the CP and AST. And we use the CP and AST to calculate their APRI score, which is the AST and the platelet ratio index. And this is calculated to find out the duration of treatment, because we use APRI of less than 1.5 as the dividing line. So people who have got an APRI of less than 1.5, we put them on a 12 weeks treatment, and those with a higher APRI are obviously cirrhotics and those with advanced disease. So we generally recommend them to be sent to the specialists so that they can look after them and manage them. So these guidelines are so simple that even a general practitioner can treat the patients at the clinics, and there's nothing fancy in it. Next slide. So then, this was in 2019 that the Prime Minister, taking notice of this disease, agreed to launch the program for hepatitis C elimination for Pakistan. And this is a 10 years program. This has two phases. The first phase was supposed to start from 2020 to 2025. And the second was from 26 to 2030. So in the first phase, we were supposed to screen 50% of the population, which was aged 17 years and above, which was about almost 88 million population, and test them for the anti-HCV, and then test anybody who was found positive would undergo the PCR and then treat them. And then in the second phase, apart from the 50% population, the children between 12 and 17 years were also included, because that's again a group which has recently been agreed and approved by WHO to be treated. So the Prime Minister's program, this table is showing you that we have recommended that starting from 2020, because because of the COVID, the program could not be launched. So we have recalculated the figures, and now it is recommended that in the beginning into 2022, Pakistan needs to treat 500,000 patients every year. And apart from treating 500,000 patients every year, and you heard that Dr. Khalid told you that we are just reaching 100,000. And we have to reduce the annual new infections by 20%. So that is where the huge gap is, because our new infection control rate in the current Prime Minister's program is falling short of achieving the elimination. Next slide. So when we calculated all this, and then we passed on our figures to Homi Razavi, who you all know is heads the Center for Data Analysis at USA. So he had a look at these, and he did the modeling for Pakistan, and he said that the Prime Minister's program is catering for a 10-fold increase in the PCR testing and treatment. And this can achieve the reductions in the chronic liver disease and the hepatocellular carcinoma and all liver related issues. But the Prime Minister's program will not be able to achieve the elimination, because until and unless the new infections are reduced by 20% each year, which is about 8 times our current infection control rate, which means that we have to really work very hard on the infection prevention, which is falling short in the program, in the Prime Minister's program. Next slide. So we have some gaps, and the biggest challenge for us is to how to bring out the population for screening, testing, and treatment, because people are very reluctant because of various issues related to stigma and to discrimination. And then we all know that though the rapid test is cheap, but the nucleic acid or the PCR or the RNA test is expensive, it is cumbersome, and it is kind of focused at the tertiary care level, while the population is in the grassroots or the primary care or even below that. And then there is a dire need, and people are working on it, that they're developing the point of care virus confirmatory tests, which are rapid tests, which can identify the virus even at the primary or the RHC or the BHU level. So once these tests are available, then things will be very, very easy for us. But right now, these are big challenges for us. Next slide. All to tackle this national emergency, we have to take the NCOC on board to tackle this national emergency of hepatitis elimination, because we think that with the NCOC involvement, we could probably be able to have a more joint effect. as we have seen in the COVID. And there's a dire need to have a public-private partnership because the government alone cannot do this. Next slide. So I think that's my last slide, is that we all know that hepatitis can't wait. Pandemics and epidemics will continue to hit us, but we have to combat them timely. But then diseases, including hepatitis, will not wait until unless they are timely prevented and treated. So we have to really just continue struggling to get these on board. And thank you very much.
Thank you very much, Dr. Huma, for another enlightening talk, and we have a lot to learn from you. I would now request Dr. Jamal Chiha for his comments and talk, and giving us perspective of eliminating hepatitis about the World Hepatitis Alliance. And indeed, we really look forward to what you are saying, because Egypt is the country which has made one of the, one of those countries which have made tremendous progress in eliminating hepatitis, and probably very close or almost achieved the goals of WHO. Over to you, Professor Jamal Chiha, please go ahead. We can't hear you.
Now, can you hear me now?
Yes, yes, we can hear you, and we can see the slides also.
Okay.
Yes.
First, thank you very much, Dr. Asad, for giving me this opportunity to speak to my colleagues in Pakistan. It is an honor for me and a pleasure. Talking about elimination of hepatitis is something that we need both to in Pakistan and in Egypt. Now I'm trying to make a slide.
We can see the slide now.
Yes, but it's difficult to now.
Yeah, we can see.
Yes, now started. Yes. So as you know, hepatitis C is a worldwide problem with 71 million infected people in all regions, including our area in the Eastern Mediterranean region. And the incidence of new cases is 1.7 million new infections per year. The problem is still huge. And it does affect the population by mortality rates. In 2015, there were 1.3 million deaths from hepatitis worldwide. And the leading cause of death in many cases was hepatocellular carcinoma complicating cirrhosis, either for hepatitis C or hepatitis B. Now, elimination of hepatitis B as a major public health threat by 2030 was defined by WHO as having 90% reduction in the new infections and reduction in deaths by 65% by 2030. And from the previous presentations, we can feel that this is a very ambitious goal that is hard to be achieved globally. eliminating hepatitis by 2030 has a package of interventions with high impact. Elimination is defined by impact indicators, the incidence and mortality. And the modeling suggests that taking 5 core interventions to sufficient coverage will achieve impact. 3 doses of hepatitis vaccine, hepatitis B virus prevention of mother to child transmission, blood and injection safety, harm reduction, and testing and treatment, aiming at 90% to be diagnosed and 80% to be eligible for treatment. The number of countries with viral hepatitis plan, this is the real situation. In 2012 to 2017, there were 17 countries having a national plan. In 2012, jumped to 82 countries in 17, and we hope that all the countries will have a national plan and become involved politically in national plans for elimination of hepatitis. Otherwise, this dream will be far away, because if you have 80 countries, you mean you have more than 100 countries with no national plans. The cascade of care for hepatitis C infection by WHO region, as we can see here, 71 million persons with chronic hepatitis C. This is worldwide. With 1.7 persons started HCV treatment. This is according to 2016. And the total is about 3 million in 2017. As you can see, there are major gaps in the diagnosis and in the number of patients treated and cured. The global hepatitis strategy, there are 5 strategic directions: information for focused action, the who and where, interventions for impact, the what, delivering for equity, how, financing for sustainability, the finance, and then innovation for acceleration. This is exactly what we need in countries where there is a national plan, innovation for acceleration. And this typically the situation I heard about in Punjab. Now, 62% of persons with chronic hepatitis C live in countries which could access generic medicines at less than $200 US for cure. And we have seen that Pakistan was very clever to have this with a very much reduced price. So the high price in other countries other than Pakistan remains a barrier. And in most upper middle income countries, Brazil, China, Colombia, Mexico, Kazakhstan, Turkey, and many others, still the price is a barrier. Now, the good practices for service delivery to support the scale-up. Here, what was suggested by the WHO guidelines is a simple algorithm across the continuum of care, strengthening linkage from testing to care, integrated hepatic testing, care, and treatment with other services, decentralization of testing and treatment. I think this is the key. Decentralization and task shifting to support decentralized care. Hepatitis is no more a disease that is treated by the consultants and the first row professors, but it could be treated by the general practitioners. Task shifting to support decentralized care is very important, and the engagement of the community. Implementation of these simplified service delivery approach was done in our center by the model of educate, test, and treat, which we have implemented in one village and then become propagated to almost 100 villages in Nile Delta and even in Upper Egypt. And this program to eliminate HCV infection in rural communities was not a governmental initiative. It was done by an NGO, and the results was treatment coverage 84%, and 17,000 infected persons were treated across 73 villages. This is what has been published in the Journal of Hepatology. And as you can see here, if you have this number of population, the target population, uptake of testing 92%. HCV antibody positive, RNA patients treated. As you can see, all those of the patients who have started treatment have completed treatment, and the viral clearance was very high. Why this is so successful? This is because we went to the people. We did not wait for the people to come to us. And we engaged the people in the community with us. And there was local funding. We go to the patients, to their villages, we do the investigations free, and we give them the treatment free. That's why many of the professors who reviewed that work were surprised. How can 99% of those who tested positive for PCR took the treatment and completed the treatment? This is because we did not wait the patients to come to the large cities to have the treatment. We give the treatment free. These patients were educated before the treatment. And there we have stakeholders. We have what we call village promoters in the villages who convince the patients and take care of them at their villages. So this was the experience. And when the government have a national program, they had the lessons from that big project. Again, what's the situation now? 2019, just before the pandemic of Corona. If you see the Eastern Mediterranean area, we have more than 12 millions who need treatment. And many of them, of course, are in Pakistan. Now, are we on the track? Progress towards hepatitis C elimination goals. On the track, the green areas are sporadic areas on the map, but the red area is still the majority, and there are many working towards the elimination. The road is still long and very long. Timing across high-income countries. 2030, how many countries will achieve the goal? The green list. But there is a long list of red list. Many countries will wait till 2050, and there are many other countries will wait 2040. So the need for acceleration is very high. Towards HCV elimination, feasibility of complete linkage to care by testing and treatment on the same day of treatment. This is what we call acceleration and focusing. What do we mean by this? We need to have the cascade of care almost complete. To do this, we have to try to implement the same day screening and the start of treatment. Is this available? The answer is yes. We have done a pilot study, one in a village and one in a big governmental building with more than 3,000 employees. The availability of the FDA-approved gene expert instrument for measuring HCV RNA viral load in less than 2 hours, and now it is 1 hour, and in the absence of sophisticated requirements, give us the opportunity to offer same-day test, evaluate, and treat. Can we do it in 1 day? The answer is yes, through development of point-of-care viral HCV screening, together with the use of the portable instruments that allow evaluation of patients and the initiation of treatment on the same day of screening. These are the portable instruments. This is the FibroScan, the mini FibroScan, the portable ultrasounds, it is there, and the gene expert point of care. And there are many other small instruments for blood picture, for alpha-fetoprotein, for liver enzymes, and serum creatinine. All the methods starts by community awareness. This is 1 week, 2 weeks before the start. So awareness, people must know what we are going to do, and the village promoters are active in educating the patients and preparing them for the work. And then 1 day before we go to the villages, there is relocation of the staff, and the staff is 21 persons, 3 physicians, 2 radiologists, 2 FibroScan operator, 1 pharmacist, 4 lab specialists, 7 nurses, and 2 data entry personnel. All 10 personnel start work at 8:30 a.m. and start at 9 and finished at 6 p.m. The care pathway screening was done using the intake rapid tests for antibodies for C and hepatitis B surface antigens. Those who are positive antibodies will go to PCR test, and we do liver and renal functions and CBC, and we do FibroScan. This diagram shows what happened for hepatitis C. Arrival at 9, registration or start of screening, and then by finger stick we have the blood sample for PCR. This took 1 hour, and then we do the abdominal ultrasound, the fibroscan, the lab investigations, finally complete clinical evaluation and prescription of therapy. This take about 3 hours for hepatitis C, and it took 4 hours for hepatitis B. And at the end of the day, in a village of 3,000 people or 4,000, 5,000, we can end with treating several hundred of people, 200, 300 of C and hepatitis B. As you can see here, the patient have his drugs for therapy for hepatitis after 3 or 4 hours, 3 hours for hepatitis C, 4 hours for hepatitis B. So the cascade of care is compact, accurate, and almost 100% starts treatment. This looks complicated, this looks difficult, but in reality, if it is well designed, it is very smooth and can accelerate the program. You have the drugs and you have the portable ultrasound, and for if you do not have fibroscan, we can have FIB4 and avoid doing fibroscan if you don't have it. So all this can be done on the same day, and in countries with large population, we can accelerate the program and treat, instead of 100,000 patients a year, we can treat 500,000 a year or even 1 million a year with the same resources. It is a matter of administration, a matter of design, a matter of implementing the lessons learned from the huge work in the villages. We can do everything in one day. We can accelerate our programs and do what we can do in 5, 6 years, we can do it in 1 year. Thank you.
Thank you. Thank you very much, Dr. Jamal Jia. What an excellent presentation and great work done under your leadership. If you can stop share, we will move to a very dear colleague, Professor Kashif Malik. He is president of Pakistan Society of Hepatology, and he will be telling us about the way forward. So Kashif, you have a job at hand in front of your seniors and teachers and everybody. So we really look forward to listen to you.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Asad. Thank you very much. First of all, I would like to say thank you to all the speakers as well as the chairs, my teacher, Professor Mubarak Khan, and my seniors, Professor Altaf Alam, Professor Hasnan Ali Shah Sahab, and Professor Javed Farooqi. I'm really thankful to Dr. Gamal for his excellent presentation and the excellent program he has discussed with us. So everybody knows that there is a consensus that hepatitis B and C, they are basically challenges for us in this real world now. We were going in the right direction before this COVID-19, as Dr. Khalid already mentioned. I was with Punjab government at that time, and we started this program. But when the COVID came, so everything got shuttled, and we are basically now having problem to deal with both these deadly diseases as well as the Delta virus. This is what Dr. Huma shared, that the Pakistan shares the 10% of the global HCV burden, and the second country in the world to having the highest number of infections for hepatitis C infections. If we go for this study, again belongs to Dr. Huma, which shows 2.5% of hepatitis B in 2008, while hepatitis C infections was around 5%. But as Dr. Khalid mentioned, in Punjab, the rate was quite high, and there are few areas, if you see, that there is very high rate of 18% or 10%. Almost 50% of the districts have more than 10% this infection rate of hepatitis C in these areas. So the challenge is very big, and we have to deal with it. Again, WHO has given the goal, as Dr. Gamal said, that 90% reduction in the incidence of hepatitis till the 2030, and 65% reduction in the hepatitis related mortality. What is going in Pakistan? The problem again, there are too many people who are very fond of having for injections. That Dr. Uma mentioned there, that we like to have injectable therapies, and the other problem is that there is reuse of syringes, which is very common in our periphery, and there is no check by the government or the other institutes on this. The second thing, which basically is that the private healthcare, the private sector is providing healthcare in 70 to 80% of these patients, and unfortunately, this is basically the private practitioners. Most of they are untrained. In a study, they showed that in Tandwala Yar, which is in Sindh, that 50% of our untrained staff are treating these patients. Third thing is the misconception, as Dr. Huma mentioned, that there is misconception because because of that previous experience of injection therapy, they are not ready for these therapies, oral therapies even. And secondly, for hepatitis B, this is if when you ask somebody, you have to continue with this treatment for maybe lifelong or for 2 or 3 years. They are not ready for this. They are not ready for having this treatment for their effects, but they are looking for their side effects, which is very common in our society. Everybody asks for the side effects and not consider the effects of that treatment for their disease. And the last thing is that most of them are unaware of their disease, or they usually come across with the diagnosis while getting some job, while giving blood donation, or sometime with the advanced disease, when the patient comes to us with advanced disease, having cirrhosis or the hepatocellular carcinoma, and then they are diagnosed to have this chronic disease with it. So these are the major problems: injection use, there's the untrained staff, public misconception, and unawareness of having the disease. So what it does, it goes with the low diagnosis rate of the disease, both for hepatitis B and C, low treatment uptake, and then low SVRs. If we see, as Dr. Gamal mentioned, this is that kind of study we have done this, that they have basically, as in a small area, they have targeted this, and the target population was 2,300. Out of this 2,300, 1,417 samples were taken for screening. Out of these, 202 were positive for anti-HCV, and 100 started on treatment, and 89 of them completed the recommended treatment. And the SVR rate was 95% in this area. This is a very good model, as Dr. Kamal mentioned. This basically has been done by the PARSA Trust by Dr. Asad. But the problem was, this was a fully funded project. Strong local area influential support was there, and clinics were within 500 meters radius, and there were motivated volunteers. So we need these kind of things to give the treatment for hepatitis C or hepatitis B to the community. So the way forward is, first and the most important step is the prevention of this deadly disease. So everybody is talking about treatment and treatment and treatment, but there should be some ways to basically prevent these infections. For hepatitis B vaccination is available. I think one should do mandatory the hepatitis B vaccination for all the people or all the students getting admission in the schools, or the people are going for the jobs. They should be screened for this, and then effective screening for both hepatitis B and C. Then comes the third part. Third part is national database should be developed. As Dr. Huma mentioned, it's a very good suggestion. NCOC has done a tremendous job for COVID-19. And as Dr. Asad was mentioning that in the previous debate in the evening, Dr. Saeed Hamid said that 35,000 deaths has been done because of these two viruses, hepatitis B and C. So this is also a mini pandemic in our area, and there should be a national database, because we have done so many camps for screening of these patients, but there's no national database. We started doing this time for the last 20 years, but because of the lack of this national database, we don't know how many of these were treated and how many of them have the SVRs, or how many have progressed to the cirrhosis or hepatocellular carcinoma. For this, civil society should be mobilized, because and educate to convince their area people for that screening, as well as for the treatment, or as well as for the vaccination to avoid hepatitis B and C. As I mentioned, there should be a compulsory vaccination from the government for hepatitis B before school admission and jobs. But if somebody comes positive with this, he or she should not be denied of admission or denied of the job, because this has happened in our country. When somebody comes with hepatitis B or C positive reports, they are denied of giving jobs for even for those jobs where it is not mandatory to have a negative report. So what we need to do is get, as again I will mention Dr. Gamal, that get out of specialty based model. Don't go for specialist. Work on less specialized workforce. Train your primary care physicians, which we are doing from the platform of Pakistan Society of Hepatology, as well as with ECHO. We are doing programs regularly to educate our primary care physician to deal with these both diseases at their district or tehsil level. And then again, community engagement is also there. Local area influential volunteers should be there. I will request government of Punjab, Dr. Khalid is here, that they should have, as he mentioned that they are working with some of the NGOs, they should expand this program, and they should reach out to the most different communities or the villages, to have the influential people there, to get them on board and start giving treatment. I must say, I must appreciate the government, even government of Punjab, they have a lot of medicine available for these patients. We have these clinics in our hospital also, and this is again the paperless type of facility which is given, and we are giving all the data to them. But it should be now should be done on a emergency basis, to reach out for these patients, and then diagnose them, and then again treat them, and simplify the treatment algorithm. As Dr. Huma mentioned, that there should the algorithm is very much there. We are using it. We are not going for expensive tests, except for PCR. If the gene expertise will be available, then it will be a great help. And test and treat, that is our wishful thinking, that we should do on the same day, that we should to test the patient there, and then same day he or she should be prescribed for the treatment. Or then comes the use of technology, which is as I mentioned, that ECHO project is there. We are using it regularly. We have regular webinars for to teach our people, and we have the volunteers in this who are going to the different villages and doing the all the needful for the people of that area. So the conclusion, in order to achieve hepatitis elimination, as Dr. Gamal mentioned, I second him, take the treatment to the people, and that is what is our plan in future. Pakistan Society of Hepatology, along with the ECHO and the PARSA Trust, we have to do this, and inshallah we will be able to do something before 2030. I am very positive for this. Thank you very much, Asad, for asking me this. presentation.
Thank you, Dr. Kashif. If you can stop share, we go back to.
Yes.
Thank you. Thank you very much. It's running pretty late. I'm sure there's a lot of interest and the people may have questions. But I would like to go straight to Professor Syed Hasnan Ali Shah, who has been leading Pakistan Society of Hepatology, and he's joining from Karachi, province of Sindh, for his comments. Shahji, if you can unmute yourself, we'd like to hear from you. Dr. Hasnan Ali Shah, are you with us? Okay, Dr. Farooqi, if you can join. Dr. Farooqi is joining from Peshawar, is one of the co-chairs of the session. Dr. Javed Farooqi, please.
Thank you, Asad. It was really a great, fascinating session. I totally agree with the speakers that the COVID has really made the elimination a bit difficult because the funds were allocated to the COVID part, but the COVID era has opened new avenues as well. And I hope that we can, after we conquer this COVID, I hope there will be good opportunities for us to coordinate all the efforts of the HCV and hepatitis B elimination, because now we are more coordinated electronically. We have got good coordination and good communication. I'm sure in years to come, it will help us how to get our objective done. And all the speakers, they have done their justice, and they have really discovered all the aspects of this Hep B, HC elimination in the COVID era. Thank you very much once again, Asad, for arranging such a great and informative and comprehensive session. Thank you very much.
Thanks a lot, sir. Dr. Hasnan Shah, please.
Can you hear me now?
Yes, we can hear you. Yes, sir.
Okay,
please go ahead.
Assalamu alaikum, everybody. I must thank Dr. Asad Chaudhry for giving me the opportunity to talk to the August gathering here of experts. And I totally agree with what has been said about Sindh. I operate in Tandol IR, and there is a lot to be done, and there's a lot of there are a lot of gaps out there in the training and the facilities and how much one can do. I tend to operate in that area. I work there once fortnight. There's a lot to be done, and whatever has been highlighted in the last 1 hour or so, we have been watching that, and the problems that we're facing, the goals that have been set, and whatever has been achieved is actually tremendous. And hats off to the teams who have been working in different parts of the world. And although it seems to be an uphill task, but while there's a will, there is a way. And I think we've got a long way to go, but inshallah, we should hope and strive for achieving what we're wanting to do. Thank you very much.
Thank you. Thank you, Shahji. We have Professor Anwar Khan, who is chairing this session. He's joining from United States. Anwar sir, thank you very much. And we would like to take your comments on today's session and any guidance for all of us.
Thank you very much, Dr. Asad. It has been a great pleasure and honor to chair this session. And the luminaries in this session, like Dr. Gamal Shiha, Dr. Huma, who has done enormous amount of work, Dr. Altaf Alam, Kashif Malik, and Dr. Khalid Mahmood. We have heard very elaborative talks from them. And I would say that Dr. Khalid Mahmood has a lot of responsibility because he is heading a program in the largest province of Pakistan, Punjab. And he, with his enthusiasm, the way he spoke, and with his energy, I think he can spearhead a very effective program. So I think we should take suit from Dr. Gamal Shiha's approach of sort of making modules and reaching the public. Unfortunately, that has not been the case in Pakistan. Therefore, we have not been able to achieve some of our set goals. There are only 9 years left before 2030. So we have to work extremely hard to achieve the goal if we can. I think the organization, the minds put together, the experts should sit together, and rather than bringing patients to the bigger centers and district hospitals, they should have more mobile units, which should be well equipped with all the equipment which has been mentioned by Dr. Shiha, and they can be, the money can be delegated to those areas and can be tested, treated at the same, at the doorstep levels. I remember we took some of our teams to these villages for treating. And when we got there, the doctors, cardiologists, gastroenterologists, everybody tested them and wrote prescriptions. And those people were just standing aghast. They said, what are we going to do with this prescription? We need to be treated. We need medicines. So I think it is the people who deserve this, leading the treatment to their doorsteps. And that can be achieved. It has been, like Dr. Shia said, it is there, the models are there. Models even in Pakistan, like Dr. Mahmood said, are there. And Dr. Huma Qureshi can put the minds together at the national level and put the provinces together to working on this. And NCOC can put a very concerted effort in bringing the data together, because now we are all linked. COVID has brought a lot of menace, but some good things too, and shook up our minds to be together and working in cohesion. So I think all of these plans are very good, but we need some very enthusiastic, very energetic teams, widespread teams who are very cohesive and put the data together and deal with it. So with this, I thank you very much for this very nice, elaborative talks, and I've learned a lot today. Thank you very much.
Thank you very much, Professor Anwar. Before I finish, we have our course director of PARSA ECHO Pakistan, Dr. Altaf Alam. A few words from him.
Thank you, Asad. It has been a pleasure to hear so many good things. All we have to do is put them in practice. I remember at the easel meeting when Dr. Shiha presented his original work for the first time, the whole world was hearing and watching with awe what he was saying. They thought that all he was doing was not possible, but he had actually done it. So we need to take a leaf from his experience and take the treatment to the people, as Dr. Kashif Malik said. Egyptian experience was that after a while, people stop coming to the established clinics. So taking the treatment to the people may be the way forward. And I'm sure Dr. Huma and Dr. Khalid have done a marvelous job in establishing clinics. People are still coming there in large numbers, but some method of taking the treatment to the people using point of care tests, like Dr. Shiha mentioned, and covering almost 99% to 100% of the population there. So that is the key. If we can do that, we will certainly win the war. Thank you very much for giving me this opportunity. Thank you, Asad, and thank you, everyone.
Thank you, Dr. Altaf. Actually, I'm feeling very awkward. It's very unpleasant to call off this meeting. It should be going on for a long time, but it's very late. I know there were a lot of burning questions and explanations, but what I can assure you, This panel, it's our job, Pakistan Society of Hepatology and our ECHO program. So we'll stay together, and probably we will be holding more of these meetings, and especially having some action plans rather than merely talking and whatever we have discussed. So I would like to thank all the panelists, especially Dr. Shihab, who has taken time and be with us. It remains for me to thank PARSA Trust and Proson's Pharmaceutical for their unrestricted educational grant for such programs. And Pakistan Society of Hepatology, Hepatitis Control Program, and World Hepatitis Alliance. So, but I will end with a note, inshallah, together we will win this war against hepatitis. And a small announcement, this session will be available on YouTube from tomorrow. For any questions, queries, we are all available. You have Uzair's number, who is coordinator of our ECHO meeting. And I see a lot of familiar names. I once again apologize. I cannot take everybody, but thank you very much. We will be calling off this meeting. Looking forward to see you again.
Thank you very much.
Thank you.
Thank you, everybody. Thank you. Allah Hafiz.
Thank you very much.
Thank you. Assalamu alaikum.
Wa alaikum.